So these are the topics for today: lung volumes, capacities. No, I don't know about the recording part. I don't know. Perhaps the team must have recorded. Usually that's the purpose of all these lectures. So over here, when we talk about lung volumes and capacities, it is actually like you will be doing the meditation. It is like that. These are the topics which are easily forgotten. But if you practice it, then it will be very easy, right? And then we'll be watching lots and lots of X-rays. These will be some very interesting X-rays, and they'll be giving you the insight that what can actually see in the X-rays. Right? We wait for about 2-3 minutes, and then we'll start. I got a few emails that sometimes it is 2 minutes here or there. And as person with asthma can get lung transplant. Well, for asthma, the problem is not in lungs. The asthma is because of the specific allergies. Right? It is the IgE mediated hypersensitivity type 1. And in that case, it is the allergic component which triggers the bronchospasm. So even if someone goes for the lung transplantation, that he or she won't be getting any benefit. There's no point. Practically, there is no point. It is like problem is not in the lungs, problem is somewhere else. Right? It is the central problem. It is the immunologic problem. So in which the antibodies are formed, and those antibodies, they are triggering the histamine reactions. Today's topic is such that if anyone joins even 5 minutes late, he or she won't enjoy it. They will be totally confused that what exactly is going on. So that's why I'm just waiting for 2-3 minutes. Take off. Lecture timing, there are hardly 3-4 students only. Otherwise, rest of the entire batch is very much comfortable with this 10:30 time. So it would be difficult. At the same time, I understand. No, you can't say that. Gentlemen, you can't use that sentence. No one is free. So you can't use that. Are there any abnormalities possible in lungs? Oh yes, so many abnormalities. So many abnormalities are there. That's why we are learning the respiratory system. You see, respiratory system is one of the commonest system to get affected. Right? In anyone's life, if there is one system which gets maximally infected, it's the respiratory system. Right. So it is 4. Let's start. So today's topic, that is lung capacities. I put all this email also over here. So ask for it. Here is the email. So topic is lung capacities and the lung volumes. The importance of this is that this would be our action plan for. First, we'll understand the lung capacities plus volumes, and then we'll immediately see that why they are important. They are important because there are 2 types of disease. As you asked, that can there be anything wrong into the lungs? Yes, very much possible. Right? One, what is called as the obstructive lung disease, and second is called as the restrictive lung disease. Restrictive lung disease. We'll talk about both of them today. We'll see that what would really happen in these cases, what would happen really in cases of lung capacity and lung volumes? At the same time, which are the actual conditions which you see in the patient? Conditions in both the cases, because this obstructive lung disease is a generalized term, so it comprises of so many things, right? And same way is the restrictive, but the mechanism is totally different. That's what we'll be watching. Once we complete this, then we'll be going for some very interesting radiographs. Radiographs is X-rays, right? So interesting radiographs. They'll be giving you very good insight that, oh, such things can also happen. Plus, it would be like a say revision of whatever we discussed till this point of time. So this is like a action plan. What you have to do in order to understand all these lung volumes and lung capacities, you'll be actually doing it, right? So it is not so that I'll just say that this is the forced expiratory volume FEV1 and this is the TLC, etc. No, this way, right? It becomes not only boring, but at the same time, when I draw, we understand, we remember, and then just after 5 minutes, it's gone. It's gone. So we'll spend some time understanding and doing it, and then we'll actually mimic that what would really happen in case of restrictive lung disease. Immediately you will say, okay, we'll be breathing like, yeah, exactly, right? That is what we'll see, because patient will be breathing exactly in the same way. We'll be mimicking it, right? We'll be acting it, we'll be dramatizing it, so that we understand that this is how the patient. So let's start. We'll give all the names, etc. afterwards, right? So here is our baseline, and right now you are sitting silently, not in those who are in the gym, right? This will only be effective. The normal breathing, the breathing where you are not focusing that any, you are not focusing on that, the inspiration nor expiration. But when you'll find that yes, you are breathing out. This is what is called as the quiet breathing, right? Quiet. So this is in inspiration, expiration, inspiration, expiration, inspiration, expiration, right? This is what is called as the quiet breathing. Yes, you can do this thing, you can draw along with it, right? So you'll be able to write some important things. So here, what is happening at this point of time? At this point of time, this is the quiet expiration, right? Right. So this is the rest or the resting expiration. Perfect. And over here, this particular line, that would be resting inspiration. How are we really trying to assess the thing? It is like as the volume, as the air goes into the lungs, so this is the number which will keep on increasing. Right? This is the number which will keep on increasing. Correct? So here, this is the inspiration and this is the expiration. Right? This is down, this is up. This much portion, right? That much portion. This is called as tidal volume. Or wait. Don't even write, right? So this is clear, right? Quiet inspiration, quiet expiration. So normally it's happening. Now what you do is, as you breathe in, right, which is a normal breathing, and it is at this point when the normal breath is over, you try to do inspiration with as much power as you can, right? Remember again, it is not so you are doing this. No, you are not expiring. You are doing normal inspiration. Then, right, take deep. This is the inspiratory reserve volume. So that means it is from this point to this point. This is the deep inspiration. Deep inspiration. As much as you can till the last point, right? Fill your entire lung with air. Fill your entire, both the lungs with air. So that is the deep inspiration. And then normal expiration. Right. So once again, We come down, the normal breathing start. Now this time, as you reach to this point, it is this point when the normal expiration has occurred. Right? So breathe in, breathe out. Then it is at this point you try to do maximum expiration. As much as you can throw out the air out of your lungs. So this, and once again, it will come back to normal, then normal. That is the quiet. You got these points? So it was this phase, very clearly. It was this phase when you were doing inspiration, and it was during this phase when you were doing expiration. Both these cases, they were forced. Otherwise, in between process, that was the quiet breathing in which the inspiration is taking the calories or it is active. Expiration is passive. There is no energy which is used, it is just going out. So this is the deep inspiration, and this is the max expiration, as much as air which you can throw out. But even if we throw out the entire air, we try to throw out the entire air, still there would be some air which would be trapped into the entire, all those stages, all those levels of the respiratory system. Because entire air, we won't be able to throw it out. It's not all possible. So this portion, there would be some air which will be left out. And the air which is left out, it is called as the residual volume. Residual means something which is left out. So it is called as the residual volume. We start with this residual volume. This residual volume, that is about 20 cc. This is about 1200 cc. Now, this much air, it is always present, this residual volume. Now, just think of that what would happen if there is some condition in which there is problem in expiration. Person is unable to throw the air out. So in that case, this residual volume is, there would be more amount of air which should be lying into the lungs and it will not be going out. If it is not going out, it means it won't be taking any part into the gaseous exchange because it is not getting oxygenated. So more air which is lying into the lungs. So that is where the residual volume would increase. Right? We'll go into the detail, but just I'm telling you. Okay? So this is the residual volume. This portion, when it was beautiful, comfortable, right, quiet breathing, that is like a wave. Right? That is like a tide. So that's why it is called as the tidal volume. Wave after wave. So it is called as the tidal volume. That's the tidal volume. This tidal volume is 500 cc. 500. So it is actually, you can say that 500 ml of air, 500 cc of air which is going out, 500 is coming in. So that is normal in, out, that's what is happening. So that's why when we try to figure out, it's a very less, very delicate, very, some air is going in and out, not the big one. When we take deep breathe, so this is what is called as the inspiratory reserve volume. Again, this is the inspiratory, right? Name tells inspiratory, yes, because we did the deep inspiration. Reserve volume, that means this is the volume which will not be using in routine, but it is kept reserved in case if it is needed to be. We use it when we exercise, right? When we are running, we need more oxygen. We take deep breath so that more oxygen goes, gaseous exchange occurs. So lungs are working. Not only that, muscles are working because we pulled the air. Yes, that's why it is the reserve volume. So this is inspiratory reserve volume, and this volume is massive. It's 3,000. 3,000. Right? The total capacity is about 6,000. Out of that, 3,000 is inspiratory reserve volume. That means when we are doing the normal quiet breathing, right, almost 50% of the capacity is still there, which can be utilized in case if it is necessary. Correct? So over here we'll draw one line. This is the topmost portion. This is where I got the maximum inspiration. Beyond that, it is not possible to take but one single unit of air. Not possible. Right? This is the maximum capacity one can take it. So now we can understand that if these are the alveoli, and if these alveoli, they are filled up with fluid, right? Filled up with fluid, filled up with cough, filled up with sputum, right? Filled up with any of the secretions. So that means that air won't be able to go it. So this means this volume would decrease. Person won't be able to take deep breath, maybe because of say fibrosis, this big area, right? Maybe because of granuloma. All these things we'll see, right? Large portion of the lung that is constricted, right? It is destroyed, alveoli are destroyed. So in that case, air won't be able to go in. If air is not going in, so gas exchange won't occur. Gas exchange is not occurring, so that means it will be reflecting on the oxygen concentration. So when it is put, so during COVID, this is what was happening. Right? Say, many times I give my example, it happened to me, right? My right lung, right middle lobe, that was totally collapsed. So that's why immediately oxygen level dropped down to a very low level. I was gasping. So this is inspiratory reserve volume. From now onwards, we'll be telling it IRV, inspiratory reserve volume, tidal volume, is the TE. Right? Then this lower side, residual volume, we'll be calling it RV. If there is one word which one has to remember, and invariably in Viva, that is what we ask, because inspiratory reserve volume, even if you close your eyes, you inspiratory reserve volume. Perfect. Right? Then how much will be even, how much we have from here to here, this maximum expiratory reserve volume, right? So if that this was the inspiratory reserve volume, so this would be the expiratory reserve volume. So far it is easy, right? Expiratory reserve volume. So this is ERV. Right? This is also easy. This is about 1100. Residual volume, that is 1200, and that is easy. So everything is fine. Inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. Residual, right? Residue means na bacha hua, something which is left out. The trick comes now. What would we call this when we combine these two things? When we combine, in other words, ERV and RV, right? It is the functional residual capacity. Why such name? Functional residual capacity. Now these things will be not volumes, but they will be the capacity. How much? How much? This is the that is the residual. How much air which is left out, and how much air that can be utilized, right? Which is lying over there. Because when we say expirate, right? Expiratory. So we are trying to throw away this. Right? It is 3000. Is what you are inspiratory reserve volume? It is 3000. So functional residual capacity is the how much air is still lying even after we go for the normal expiration, right? So this is called as the functional residual capacity. This is now, these are all capacities which we are talking about. So we have got resting expiration. That is what is occurring at the end of the quiet breathing. So this particular line, at this particular line, can we say that it is the functional residual capacity? That much amount of air is left out into the lungs. Correct? Resting expiration, it is at FRC. Because even when the normal expiration has occurred, still we have got that much air which we can forcibly throw out, and still there is some air which is left out. So in other words, it is the combination of expiratory reserve volume plus residual volume. Fair enough. Right? So this was easy. This tidal volume which is the ERV plus RV is equal to FRC. That's right. So ERV plus RV, this is equal to FRC. So this is settled. Now only one term is to be. As such, logically, if we see that what is the total capacity of the lung to take the air in. So at this point of time, this is the junction, this is the crucial junction. From this junction, there is a clear division. This is the normal inspiration, and then it would be like a forceful inspiration, but finally it is inspiration. So from this point onwards, all the way up, this entire thing. That is our total capacity, what we can take the breathing in. So this is what is called as the inspiratory capacity. Easy to understand? Because that's the maximum air that can be taken inside. Didn't understand FRC? Yeah, FRC written in the resting expiration. Yeah. So this point, this line. After this line, what do we do? It is after this line, that is at the end of quiet expiration. Breathe in, normal breathe out. And then it is at this point we are standing. And then forcibly you try to empty the lungs. So you reach to this level. So that was what? That was expiratory reserve volume. Expiratory reserve volume. How much air can you throw out? When after that also, there is some air which is still lying, right, which we cannot empty, right? That would be lying deeper into the spaces, all those tubes. Right? So even if the lung has tried collapsing, but still there is some air which is, because it never collapses to 100%, right? It never happens. Some things, they are always open. So some air always remains. That's why that is the residual volume. So the level, this level, won't this level be the resting expiration? Right? Won't this level, this line which we are drawing, right? It is the resting expiration because this is the inspiration, this is the expiration normal. Right? So that's why this particular point, beyond this point, everything is functional residual capacity. Right? Is the functional residual capacity. All the way emptying from here, where there would be no air, to this point. So that's why this is functional residual capacity is at resting expiration. Easy. And this is why over here, this point, this line, that is when we have done the quiet inspiration, so that is resting inspiration. This one. When we have taken full load, all the way, whatever the air which we can breathe, so we reach to the maximum level. So this is the maximum inspiration. It is at the maximum inspiration. It means at this point of time, it is the total amount whatsoever we can take, breathe. So that's why it won't be a good idea to all the way from this point to this point. Just name it as kindly mute. Capacity. Do not revoke the rights. You'll be able to unmute yourself in case it exists. So coming back to this. So when we take full breathing all the way, whatever the air which we can take it, So that is the point when the lungs are totally filled. Beyond that, it cannot be filled. Right? Beyond that, it cannot be filled. That's why we call it TLC, or the total lung capacity. That is the total lung capacity. So this total lung capacity will be the total of everything. It is the total of inspiratory capacity and the functional residual capacity. Correct? Or we can really say that it is the total of inspiratory reserve volume, this one, plus the tidal volume, plus the expiratory reserve volume, plus the residual volume. Makes sense? That is the total of all of them. So IRV plus TV, IRV plus tidal volume, yes, that is inspiratory capacity. No, that is inspiratory capacity. You are right. All right. So this is a inspiratory reserve volume plus the tidal volume. That's right. That is the inspiratory capacity. You are absolutely right. Okay. Then inspiratory capacity plus FRC, that is also right. I was just coming to that. So over here, when we say this FRC, functional residual capacity is what? This is expiratory reserve volume plus residual volume. So expiratory reserve volume plus residual volume. So very right. We can, instead of this, we can just say this also, that inspiratory reserve volume plus tidal volume plus the functional residual capacity. That is also true. Or one more way we can say that the total is inspiratory capacity plus the functional residual capacity. This is also the total lung capacity. In USMLE, they do ask such type of questions. Because when the options are given, the total lung capacity is this or this or this. I mean, out of all of them, only one would be the right answer. But this makes sense. Once you have understood this, table, just once, that's it. Now you'll be knowing all the experience, all the obstructive and restrictive lung diseases. Trust me, it would be so easy. Any doubt in this? In case if there is any doubt, just let me know, because now from this point onwards, it would be difficult to come back to this because we'll be using all these terms now. So if it's still clear, great. So instead of taking for the physiology part, straight away I'm taking you to pathology. Because once you see the implementation of it, then we'll be going for the further details. Two things can happen. This is a lung. Just we are taking, for the example, we are just taking one lung. It can happen in both of them. What goes inside, that is inspiration. What comes outside is the carbon dioxide. Okay, we have understood that, but it is like what we breathe in is mostly oxygen, what we breathe out is mostly carbon dioxide, correct? Because it is always a mix. What we breathe in is called as the inspiration, what we breathe out is called as the expiration. True, the trouble is pathology can occur at either this point or at this point, right? Pathology can occur. So when person is having trouble inhaling, person is unable to inhale, person is unable to do the inspiration, where the things can go wrong. It's I say that you land at the airport and from airport you come down to my place. What can really go wrong? If you are not reaching, say I said that you will be able to reach within 40 minutes. It's 1 hour, still you have not reached. So either car can go wrong, right? The cab in which you were traveling punctured, right? Something happened to that cab. Or what is if there is so much of traffic, Both the things can happen. So that is when there is trouble in inspiration, when there is a trouble for the air to go in. This is called as the restrictive lung disease. Understand it very clearly. It is called as a restrictive lung disease. Because in pathology, straight away these terms are used, that in restrictive lung disease, there would be pulmonary fibrosis, there would be sarcoidosis, neuromuscular disorders, and then all those things will come. But this is the point. There is trouble inhaling, right? Trouble inhaling. Where the trouble can go, let's just see. So now expiration, you must have guessed, right? So if there is trouble exhaling, when that thing can happen, this thing can happen when there is something, the air has entered, but it cannot go out, right? So this is a very typical thing. This is what is called as the obstructive lung disease. Obstructive lung disease. Make things easy. When the lung has become lazy, lung has become lazy, right? All those paths, they are narrowed, right? Inside, there are mucus, right? So there must be a wall mechanism. Right? So let's say this is an alveoli. If this is an alveoli, and we say that, okay, if this alveoli is totally destroyed, if it is destroyed, so there air won't be able to go in. So air cannot go in, so it won't be able to come out because no air has gone inside. This is a reverse. This is the thing in which the air has gone inside, but now it is unable to come out. This is where the breathing patterns, they will become right? Breathing patterns. So, for example, in case of emphysema, the patient's chest is that huge, big one. Again, another important point in obstructive lung disease, these are all long-standing. It won't occur overnight. They are all long-standing. Say, for example, the commonest, what is called as the COPD. Chronic, the word C, chronic, right from the beginning. Right? It is chronic. So, chronic obstructive pulmonary disease. Right? This is the chronic disease, which is a long-standing. Right? So, this chronic obstructive pulmonary disease, this two major, it is what is called as the emphysema and chronic bronchitis. But see this is a chronic condition. Both of these conditions, they take time, right? They take time. So over here, these are the obstructive lung disease. We'll be talking about the examples in a minute, but this is the concept. So do remember that when we talk about exhaling, it is obstructive lung disease. When there is a trouble inhaling, it is the restrictive lung disease. First, instead of going for the condition, we just understood all our lung volumes and capacities, correct? So let's draw something so that it gives a clear idea. Okay? So here it is, our normal say this is our normal TLC, total subspace. Deliberately, I am drawing our normal slightly normal one. So this is a normal total lung capacity. Normal total lung capacity was combination of 4 volumes. Correct? Out of those 4 volumes, let's keep this thing 500 ml chota sa. That was our tidal volume. Correct? Then deep inspiration, this was our inspiratory reserve volume, clear. And then there was the expiratory reserve volume, correct, which was about 1100, and this is the residual volume. So this is how, in this proportion, right, we have tried to keep the things in as much proportion as possible, right, because this was about 500 ml, this was about 3000, and this was about 1100, and this was about 1200. So roughly as per the question. In case of obstructive pattern, so what obstructive was doing? The problem in exhalation. That means air is remaining into the lung. That air which is remaining into the lung, it is not coming out. It means which component should increase is the residual volume. Make sense? Right? So if we really draw it like this, so this residual volume that has increased. Otherwise, for rest of the things, right, they are almost of the same size. So expiratory reserve volume is of the same size. That tidal volume is of the same size. Inspiratory reserve volume is of the same size. But this portion is increased. Exhaling problem. Exhaling. So this is what we see. Obstructive. This is the obstructive pattern. If this is the case, right, in case of obstructive pattern, so now see the residual volume that has increased. So this one will be, left one is abnormal. This is abnormal. These are pathological conditions. Obstructive pattern, obstructive lung disease, or restrictive lung disease. Both are finally to pathology, abnormal. So this is a normal, me and you, this is how it goes. But if someone is having this obstructive pattern, obstructive lung disease, so then it is like this. Their residual volume, that will increase. So from where this air will go, it will remain inside only. Right? It will remain inside only. When it is remaining inside, that means the chest size that will be bigger. The chest size will be bigger. There will be more space inside. Right? Just keep this concept in mind that there will be more space inside. Now, is this space good? Not necessarily. It could be filled up with so many other things. Right? So that's why this trouble is happening. Expiratory reserve volume. Well, this expiratory reserve volume, when as compared to as the condition deteriorates, right, this volume would also decrease. Right now, we are just for the sake of understanding here. Otherwise, every parameter would change. Yes, you are right. Every parameter would change, plus or minus. But we are trying to keep simple. Then, condition by condition. Next time, my plan is to draw all the graphs, right? To draw all the graphs, because there will be one concept, what is called as FEV1, FEV2, FEV3. I got the device also, so I'll show you the device also. That how to measure from it. It is an electronic device. So you take deep breath and then you जोर से फूकना, and then keep exhaling as much as possible, because that instrument, it will keep on calculating that how much air was pushed in first second, then how much was second, so how much was in third second, and then it will display the results. We'll see that thing next time once we have understood it. So there would be a change into FEV1, V2, V3, all those parameters will change, and then we'll plot the graph. So looking at that graph, create the picture that this is how these conditions they are. Today's session and the next time what we'll be taking, these two combination. Yeah, it is digital spirometer, right? One spirometer is a mechanical spirometer, this one is a digital spirometer. That's right. So it would be the combination of. Now moving on to the third. This is inhaling. Air itself is less, air is going inside. So obviously the whole TLC is going to come down. So whole TLC, that is down. So every parameter would be decreasing because less air is going. So it would be decreased, everything decreased IRV, decreased tidal volume, expiratory reserve volume decrease, residual volume decrease. So this is in case of restrictive. So this is where there is trouble inhaling. some conditions which you should really know. One is of obstructive pattern. The COPD, this would be the most commonly heard bronchial condition or the respiratory condition. It is chronic obstructive pulmonary disease. So from now, with the full form, we know that it is not talking about just one particular. It is a group of diseases. It is a group. Those who are chronic, those who are obstructive, those who are related to respiratory systems. Pulmonary disease, that means respiratory disease. But the point is, this is obstructive. Very easy. Right? Out of that, first is emphysema. Emphysema. And second is chronic bronchitis. Itis, wherever the word itis comes, that means it is inflammation. Appendicitis, tonsillitis. So that means we are talking about the inflammation. There is swelling. Whenever there is swelling, there would be edema. There would be the redness. There would be the loss of function. And all these things collectively, they will be decreasing the efficiency. Right? They will. So this is the chronic bronchitis. Acute bronchitis can occur because of some immediate infection which occurs. But this is chronic since, right, months and years it is happening. So every time person is coughing, so gradually it happens like there is so much of tissue destruction that many of the dead spaces they are created. That means those spaces, the lung will never go back to its original state, the compressed state. Right? It will remain inflated to some level. And when it is remaining inflated at one particular level, that means it is not collapsing. It's the amount of, though air is inside, but that air is of no use because it is just lying over there. It is not even giving space to the top air, right? It is like this alveoli is like this, right? And there are only some places where otherwise this is all filled up with fluid, etc. But whatever the air which is lying over here, that air, unless it goes out, right, it won't be allowing other air to come in. So if there is large amount of air which is trapped into these spaces, so this is like, even though there is air, even the chest is expanded, person is breathless. This is what really happens. So remember, this is the pattern in which exhaling is problem. Then the second very common is the asthma. Asthma. In fact, when there is bronchoconstriction, here the constriction is if these are all deletions. Asthma is what we'll be discussing even in physiology. But what if these mid ones they constrict? So over here, the rest of the air which is over here, it is trapped. It is trapped. Yeah, all these things they come in the obstructive pattern or the trouble exhaling. So when the air is not going out, the person is like the air which is inside, it is having CO2. It is having CO2. So what patient will do? Patient will take the extra effort to pull the air in. That's why in case of asthma, you will hear wheezing. That way, right? He's trying to take the air in. So the whole thing is that this is the path. In between the path is constricted, and over here there is air, and this air is to be thrown out. It is not going out. New air is problem coming in. This is all happening because of the asthmatic attack, which is because of the allergies. The third and very typical is this is the bronchiectasis. Ectasis, ectasis. There is permanent enlargement of these bronchioles. The key word is permanent enlargement. That means they don't at all collapse. Permanent enlargement. And then plus there is large amount of very heavy mucus secretion. Heavy mucus secretion. And that is comes out. If you really see the patient of bronchiectasis, the amount of sputum which comes out, right? Yes, it is extremely heavy. They take out that cough so much, right? The bowels, they get filled up. So this is bronchiectasis, and it is very smelly. Another thing, what is called as the cystic fibrosis. Later on, because the X-rays of these conditions, they are very difficult, as will be proceeding. Inside is sputum, outside is cough. No. Cough is what is a layman language. From the medical terminology, from the medical point of view, when we say cough means khasi, right? Cough is khasi in Hindi. Cough means khasi. Patient tells cough means something what comes out, right? Sputum is what comes out. Inside is the mucus. Inside is mucus. When it comes out, it is called as the sputum. But when we say cough, right? So cough means khasi. Right? We last time we talked about it. The layman, the patient would say cough nikalta hai. Cough is not. Cough is a procedure. Right? Is cough. That's right. So now coming back to the cystic fibrosis, this is a genetic disorder. This is a genetic disorder. So when we will be learning genetics, we'll be talking about the cystic fibrosis in quite a big detail. But the problem over here is that it is the mucus plug, right? Mucus comes out, and it is that mucus which plugs or clogs the pathway. It stops the pathway. So here is the entire pathway, and then in between, right, that mucus sticks. So now the air which is over here, this air is trapped. So it is the mucus which plugs or clogs the pathway. This is what really happens in case of cystic fibrosis. So all these cases, you will find that when the X-rays, I'll show you. Next time I'll try to show you all these X-rays, because today we'll be discussing those X-rays which are like very typical X-rays and some findings. This is cystic fibrosis. Cystic fibrosis, it is a genetic disorder right from the birth. And in this, there is so much of mucus production. So that mucus production, it is thick. So it clogs the path, right? Clogs the path. So if we say, and it never happens like trachea or primary bronchus or anything happens. It is this in this tree, deeper in the tree, right? This is where it forms. This is how it gets formed, all these plugs. Right? They will plug. So any alveoli which is after that, so this air is trapped. This is what is called as the cystic fibrosis. The name is cyst. Cyst means fluids filled space. So that is cystic, right? Fluid filled space. And this is in combination with fibrosis. Right? When the lung tissues, they are destroyed. So this is how it really, what the reason for sputum secretion. If it is like cystic fibrosis, so it never goes. Like it keeps on. In bronchiectasis, again, it is a very chronic condition. It takes quite a long time. It takes quite a long time before the entire bronchial structure is enlarged, and it is so much enlarged so that the collagens and everything is destroyed, so that those alveoli, they are like very loose balloons type of, right? They are expanded, but they cannot collapse. So when they cannot collapse, so air won't go out. If the air is not going out, so that is what is called as the stasis. It stays over there. Ectasis means enlargement and the air stays inside. And when it happens, so this is combined with very, very heavy mucus secretion. So there will be heavy mucus secretion. All the alveoli they are secreting, right? Everywhere. And when such a heavy mucus secretion is there, so cilia will try to throw it out. So finally it comes out in the form of heavy sputum. Because the tissues are destroyed, that's why it will be combined with blood, it will be combined with some infectious material, so much of it. So that's why these are the conditions. If you see the bronchiectasis, next time definitely I'll show you all the X-rays, right? Emphysema, yes, I do. Emphysema, so many. Common bronchitis, yes, asthma, bronchiectasis, all. I'll show you all the X-rays, multiple X-rays. Next time we'll spend about 15-20 minutes on these X-rays. Okay. Next we are talking about now is the restrictive pattern. Restrictive pattern. I agree. None of these, right? In first MBBS, they won't be asking you any of these conditions for the diagnosis, right? Because all these are huge topics, But why I'm introducing these words into your mind, plus I'll be showing you the X-rays because it will start creating a picture. And again, physiology is yet to be discussed. Okay, so restrictive pattern is a pulmonary fibrosis. Simple. Because over here, what do we see? There is trouble inhaling. So this is the trouble inhaling. There is no space inside. The tissues, right? Those air spaces, they are now fibrosed. They are fibrosed, right? That means instead of this, right? These are the fibers and they have stopped. Now air cannot go in. So if it is happening to multiple alveoli, obviously which are the entire lung will be having very less capacity. Why fibrosis can occur? So many reasons. Right? We'll discuss that. Second, this is sarcoidosis. Now what is that? This is in simple words. It is the inflammation. Whenever there is inflammation over here, there would be those inflammatory tissues, they will start making a ball. Right? They'll start making a cluster. Is the trouble in healing? That's right, trouble in healing. I wrote it. So over here, the inflammatory tissues, they will make a ball. That ball would eat up so many alveoli. So that inflammatory tissues or the cells, when they are combined, so it is like a cluster. Cluster means group. Cluster means group. So it is not one cell, two cells, millions and millions of cells, and then they make a cluster or a group. This entire thing, in one simple word, is called as a granuloma. Whenever the word comes oma, that means it is that tumor, right? Benign or malignant, this is benign, right? This means this is some collection, this is space occupying lesion, right? Instead of this, just keep it. This is space occupying lesion. The lesion, which is, no. This, forget about the tumor, right? I was knowing it, this question would come. So don't worry about the tumor part. Even erase that thing, right? Just consider space occupying lesion. Because then unnecessary will be going into the details of malignant. It will be deviating from the topic. So what I mean to say is, these are like spaces, balls which are created into the sarcoidosis, into the lungs. And obviously these are the inflammatory tissues, group of tissues, and that tissue which has been formed is useless, right? Because nothing, not a single point of air can really go in. So it is practically useless. So that is where the capacity of the lung has decreased. Third, The capacity of lung depends upon, right? When it is a normal, quiet breathing, fine. When we need to breathe forcibly, that means those muscles should work properly. What if someone is having neuromuscular disorder? I use the word neuromuscular, right? Neuromuscular. So this neuromuscular disorder, it can occur in, say, so many ways. No? Few ways so we have even discussed when we discuss that neurotransmitter. So during neurotransmitter, we say that anything if it is presynaptic, right? Something is happening and our acetylcholine, that is bichara, it is unable to release. Lambert-Eaton syndrome. Right? Something happens that our receptors over here, the patient's receptors, right? They are destroyed. So from here, the depolarization signal is not forwarding and the muscle is not contracting. Myasthenia gravis. So all these things, they are collectively what? Neuromuscular disorder. Correct. In both these cases, what is happening? Muscles are not contracting, whatever may be the reason, whether it is a presynaptic thing or it is a postsynaptic thing, whether it is Lambert-Eaton syndrome or it is a myasthenia gravis. But in both these cases, simple words, depol is not forwarding, right? Depolarization is not forwarding to the muscles. If it is not going to the muscles, muscle won't contract. Muscle won't contract, then problem in inspiration. Correct? This is one thing. Or it could be signals are going good, but the muscles are useless. That is what is called as the muscular dystrophy. Muscular dystrophy. The muscles, they have become so weak, right? Atrophied, dystrophied muscles. So in elderly patients, many times you must have seen that their chest size is so small, right? The muscles, they are so small. So that is the reason. Gentlemen, sarcoidosis, I must have explained 3 times. Right? And then it is written, it is so simple. It is just the cluster or group of inflammatory tissue. That's it. So that is what makes that granuloma. Granuloma is nothing but space occupying lesion. So in this entire lung, if this is the thing what is created, then obviously that space is destroyed. It won't be used. You can't use it for the LSTs. Okay, coming back to this neuromuscular disorder. So this is the neural disorder or it could be the muscular disorder. 2 things they can do. So collectively, that is what is called as the neuromuscular disorder. So this can occur. And 4th, if there is so much of weight which has been put on the lungs, extreme obesity. Extreme obesity. So when the person is very much obese, very much obese, so there would be, because of the excessive weight, the lung would be compressed. Lungs would be compressed. Why lungs should be compressed? Because the diaphragm which is there, right? That bellies, they are huge. So that's why they said that if you want to become a very good athlete, first thing what you do is your chest, that should be not only more than waist, but there is a golden ratio. Right? There is a golden ratio. That is, if the waist is 32 to 34, right, in case of males, and the chest should be about, say, 44. So this is that ratio which will give you tremendous benefit, right, in any of the sport. So extreme obesity, the belly is so big, there is so much of fat that it will push the diaphragm up. Now, over here, though, it is fixed. Na? Neck is fixed. So this neck, right, I'm not drawing it into proportion, just this is the neck. So that is fixed. Bichara lung is over here. When the diaphragm goes up, the lung is compressed. Now lungs, they don't have that much space, and this thing is called as the hypoventilation. Right? So extreme obesity, hypoventilation. This entire thing is one. Right? It is spoken together. But I broke it so that we understand the process. Ventilation means normal breathing, right? In, out, in, out. That is ventilation. Hypoventilation is when the breathing becomes, right? That is hypoventilation. And when there is shallow breathing, so then it can lead to hyperventilation. Hyperventilation is like this. That is hyperventilation. When you are running, so if you don't see giants extremely obese, yes, there are people. I mean, they are in the range of. I know one person. He is just 145 kilograms, 145 kilograms, and he is so fond of eating. What to say? Means, I mean, at times their entire philosophy changes. They say that, अरे दोस्त खा पी के मरो, मजे से खाओ, ये क्या घास फूस खाना. When you eat salads, ये क्या घास फूस खाना. He eat all junk foods, and in 1 year, from 122, he has gone to 145. So यही हुआ ना, मतलब this 145 kilogram. So if you convert it into pound, 145, this is 2339, is almost what? This is more than 400, right? Because 145 kilogram, that comes to 390, and then add another 20, this is 40. So yeah, it will be 440 pounds. It will be 440 pounds, right? That's just how to convert it. Very easy. 100 kilograms, right? You want to convert it to pounds, double it, right? So this is 200, and plus add the 1/5 portion, so that is 20. So it will come to 220 pounds. 100 kilogram, that is 20. So that is dangerous. So this is what is called as extreme obesity, hypoventilation. And in this case, the lungs are badly compressed. Lungs are compressed. When lungs are compressed, these are some very important, very vital things about obstructive versus restrictive. And when I'll show you the X-rays, it will blow your mind. Yes, this is so typical. These are they will be like mathematics. Once you see them, you will never be able to forget it. So now we know about this. So can we summarize something so that it will make entire thing very easy? Plus, then we'll be adding some extra points. And these extra points will help you in understanding that it is not so that just one number. That number is so dynamic, it keeps on changing. So over here, for the total lung capacity, see, total lung capacity means it is total of everything. When we say at the maximum inspiration, yeah, that is the maximum inspiration. So where are we at the maximum inspiration? At the topmost level, that is at TLC. Correct. This is clear, right? When we are at the maximum expiration, immediately, where are we when we are doing maximum expiration? So at what point are we? At what point are we? We are at which level? We are at which level? When there is maximum expiration. Normal breathing, inspiration, expiration, and right, we have no. One correct answer came, but suddenly so many incorrect answers. Arey dost, wait. Maximum expiration. Right. This is maximum expiration. He reached to this point. So then whatever is left out. When you say functional residual capacity, means it is expiratory reserve volume plus residual volume. At the maximum expiration, you are at this point. So how much is left out into the lungs? Those who have said RV, that is correct. Right? How there is, how is ERV, expiratory reserve volume? Why we are not here? Expiratory reserve volume we have usko par kar diya, right? And then we are at this point. This is the point of max expiration. That means how much is left out in lungs? Only the reserve residual volume. Yeah, only the last portion. Right? Right? Only the last one. Functional residual capacity was so ERV plus RV. Right? So which point is this? Chalo. If I say, if I don't write anything over here. So at functional residual capacity, which process is going on? We are at which process of breathing? Maximum inspiration, maximum expiration, quiet inspiration, quiet expiration, where? Where are we? With Monalika, think again, think again. Is here part expiration? I don't understand. What is part? Part is partial. Try to recollect the word. Yes, Anil, you are right. Yes, you are right. Residual volume, those residual volume is here. Those residual volume is here. अभी तो बात हुई. अरे अरे अरे. Maximum expiration. Why so many mistakes? अरे इंस्पिरेशन. वेट, इंस्पिरेशन कहां से आया? No, there cannot be so many incorrect. See the correct. There is such a simple. This is what. Chalo. Those who have answered incorrectly, right? Those who have answered other than quiet expiration, not inspiration. Not inspiration. This is quiet expiration. Na? देखो यार, this is inspiration. Quiet inspiration is here. Quiet expiration is here. मैं नाम नहीं ले रहा किसी का, but no, I don't want to insult anyone. नहीं, बुरा मत मानो दोस्त, जिन्होंने क्वाइट एक्सपिरेशन के सिवाय इतने सारे आंसर्स, प्लीज थिंक इट. I don't mind explaining it 10 times, but if this is the problem, trust me, next time, मतलब, I'm not insulting your intelligence, but दोस्तों समझ लो, next time का lecture will be total bouncer. I'm telling you seriously. Because when we'll be adding one more scale unit, and that would be the time scale. When I'll be telling that we are going for forced expiratory volume in 1 second, 2 seconds, 3 seconds. So this means when you breathe and then you tell the patient, do the expiration. So then expiration goes like, and then slow, right? So when I'll draw the graph would be going like peak first second, and then second second, and then third second it goes slow. Got it? Got it now? Right? So this is how it goes. So when we'll be adding the timeline, resting expiration is completely right? It is not wrong. If you are getting quiet respiration or resting expiration, they are correct, right? But if someone has written inspiration, oh, then this is a trouble. Then it is a trouble. Inspiration तो कहां से आया? अभी के लिए Uh, if you remember, if you don't remember those values, 3000 ml or this, it's okay. But TLC is not 3000, boss. TLC is 6000, right? Lung capacity is about 6 liters of air. Na? 6 liters of air. 3000 to सिर्फ अपना inspiratory होगी. Just have a look at it. Just so that you get that, right? So this is 3000. Just inspiration, because that is a big capacity. Tidal volume 500, that is normal. सभी में वो same ही रहता है. There is not much of that. Expiratory reserve volume, yes, you can increase it. You can increase it. When you increase it, this residual volume will decrease. And then I'll show you even some of the exercises also by which you can increase your capacity. That you can't make your lungs bigger, but you can make them more efficient. So as I said, that being a doctor, you should be the most efficient person, whether it comes to cardiovascular system or it is breathing. But I am a bit disappointed by these answers. Chalo, let's go for one more round of questions. See, this is request to all of you. नहीं समझ आए ना तो हाँ मत करो. Ask. But I ask question and then if this happens now, then it is like, what were we doing since 1 hour? And trust me, these graphs are superlative things. They are so beautiful. Matlab, you see it and it will come in your mind, this is how patient will be. Right? In seconds, you will understand. What would happen at, let's say, this is the point. Which point is this? What physiological action is occurring at this point? Rapidly, I'll ask you. I need to buy एक ना रिमोटली मार सको ना, ऐसे आप जैसा स्केल लेना पड़ेगा. यार यहाँ पे एक्सपिरेशन कहाँ से लाई? फोर्स एक्सपिरेशन. थिंक अगेन, आंसर अगेन. यू कांट आंसर लाइक दिस. Yeah, so many. This is the inspiration. Be specific. Which inspiration? हाँ. Those who have written, बड़ा simple to बड़ा simple. हाँ. You can't write tidal volume, दोस्त. Viraj, नहीं यार. Tidal volume is what? Tidal volume is this, right? It is the combination how much air goes in and out. यहाँ पे क्या होता है? If those who have written, say, resting or quiet inspiration, you all are right. But please, those force तो यहाँ पे है. This is the point when the forced inspiration is done. है ना? Forced inspiration वाला portion ये है. This is normal inspiration. This is forced inspiration. This is normal expiration. This is forced expiration. So, and tidal volumes, it is just this 500 ml. It is not an event, right? यहाँ पे event कौन सी चली? Quiet inspiration, right? So then in, out, in, out, in, out, right? So that is what is happening. Okay? Right? Then over here, what must have occurred? Forced inspiration, right? So that we reach at the top. So यहाँ पे कौन सी value आएगी? Which value will come over here? Which value? Which value will come? That is 3000. यहाँ पे 3000, सिर्फ 3000. Lungs में कितनी air होगी at this point of time? यहाँ पे. And what is that value called as? What will be the value? Maximum inspiration, that is inspiration. Chita, what I'm asking is, यार 3000 तो यहाँ पे होगी. This whole thing is into the lungs. So कितना हुआ? And what this is called as the total. That's right. Total lung capacity. That's right. That's the total lung capacity. You are getting the idea. Total lung capacity. That means full lung is filled with air. So that will come to about 6000. Correct? Because see, the 3000 तो यहीं पे आ गया. अच्छा. What point is this? Which event has occurred at this point? At this point. Now are again forced. If you have written FRC, so that is correct. Functional residual capacity. So I'll agree to that. Right? That is totally fine. But expiration, मतलब force कहाँ? हाँ, मैं repeat किया last time का question. True. Force तो दोस्त यहाँ पे है. ना समझो ना. This is like quiet expiration. Just a small thing. Quiet की spelling. This is not QUIT. Quiet means casual. Like how happy you are? I'm quite happy. So it is that quiet. This is quiet. Quiet matlab shant. Right? So thus correct the spelling is QUIE. I mean, if you speak quiet, so no one will challenge you कि अरे spelling में ऐसा. But still, sometimes जो कहते हैं वो छोटी सी चीज, people judge you by that. Just remember. Those who have written forced, God's sake, remember it. This is the normal tidal volume. ठीक है? Please. I don't mind. थोड़ा ध्यान से एक बार फिर से देख लेना, because next time we'll be discussing. Next time we'll first 5-7 minutes we'll revise this. We'll quickly revise it. We will be going for graphs. Full session will be on graphs and all the X-rays. 6000. Inspiratory capacity was how much? 3000, right? Then tidal volume was, inspiratory reserve volume was 3000, tidal volume was 500. उसके बाद expiratory reserve volume was how much? About 1100, and the residual volume was 1200. So when we make a total, this is 5, 6, 7, 8, right? 3, 4, 5, roughly 5800, roughly 6000. RV को भी count, because RV is what? RV is the amount of air which is present into the lungs. है तो सही ना? So we have to calculate all of them. And this is what is called as the total lung capacity. Very logical. The amount of air which is present into the entire lung is the total lung capacity. Now we just talk about one important concept, and which is called as the closing volume. Closing volume. Dhyan se suno. Very carefully. Closing volume. Roughly 6,000. That's right. Because these two values, this and this, they do fluctuate. So as such, 6,000 tak pahunch jata. Coming back to this closing volume. Closing volume is that volume which is just above this residual volume. So in which, and this thing, it varies. Right? It varies. So as the age increases and when the person becomes weaker and weaker, this volume, it approaches the FRC. So what happens? I'll show you. So let's say this is the lung. Right? Divide it into two parts. Let's say this is the base and this is the apex. Base is under the pressure. Right? Base is under the pressure. Kiska pressure? The pressure of the own lung, right? Own tissue. So this apex part, that is the upper lobe, will be generating pressure on the lower lobes. Right? So when the lung, the entire lung is so delicate, when the entire lung has to collapse, so the base would be collapsing first or the apex would be collapsing first. Base would be collapsing first, right? Because upar se weight aa raha hai, to, right? The base would be collapsing first. So the base will be throwing the air first, and then the apex will be throwing the air out. Right? So this means that the airways of base, they will close first as compared to the apex. Right? So just remember, base of the lung closes first. Bas. Right now, even if this much is clear, is enough. Now I'll show you some of the very interesting X-rays. This one. What is it? We'll be able to diagnose very fast. Watch all corners. Right side X-ray. Okay, this is the right side. This side is right. There is nothing like a right side X-ray. Nothing like right side. Okay. This X-ray is of a female. Okay. That's the marker. So that's not a diagnosis, it's just a marker. Okay. Heart ulta hai. Right? This is dextrocardia. That's right. Now you are right. Anand, good one. This is dextrocardia. Heart is on the opposite side. It is not tilted. It is actually the whole heart is on the opposite side. The heart normally it is like this, right? But this heart, this is completely on the opposite side. See the arch of aorta, everything, it is on the opposite side. So this is right-sided heart of the dextrocardia. This is normal. This was a casual finding. This female was absolutely fine and she came just for the routine health certificate, fitness certificate. And when the X-ray was taken, it was found that she's having dextrocardia, but she's not having only dextrocardia. She has got even situs inversus. Situs inversus. That means all the organs of the body, they were also on the opposite side. See, this is the gastric bubble. Gastric bubble. Gastric air. Right? This is the gastric bubble. I'll just remove this thing so that you can see it. Let's mark it like this. Gastric bubble. And on this side, there would be liver. So that's why, see, it is absolutely radiopaque. Correct? So this is gastric bubble. This is stomach. That's right. This is stomach. So this is dextrocardia plus situs inversus. bilkul. We talked about it that the heart is on the opposite side, but if the entire, it is called as the gut rotation. Gut rotation. Gut means the embryologically, right, when we be studying embryology, this is called as the foregut, midgut, and the hindgut. So these guts, there is first a tube is formed, and then that tube folds. And after folding that tube, the whole tube starts rotating. Right? In the process, some of the tissues will form in between. So that is how the pancreas would develop, and that's how the pancreas. I'll just draw it over here, right? So let's say this is the stomach, and then C loop of duodenum, right? C loop of duodenum, and then the duodenum, jejunum, ileum, all those things would develop. This is over where there is appendix, right? That's the ascending colon. Then there would be the transverse colon. Then there would be the descending colon, correct? And I'll change the color. It is in this space, right? It is the C loop of duodenum from where the pancreas will go. This pancreas will be going behind the stomach, right? Behind the stomach. So that's why it is retrocardiac. And then over here, there would be spleen. And on top, all of them, right? Over here, there would be the liver, correct? In the liver, there would be the gallbladder. From the gallbladder, the common bile duct that will go out, right? It will open into the second part of duodenum. Meantime, this is what all the way from this one would be the pancreatic duct, right? It will open. This is what is called as ampulla of Vater, right? And this will secrete the juice, and then that thing will go for the digestion. So this is how things in dextrocardia, right? When we'll study the rotation of the gut, this is so amazing that how one by one, the structures they start falling into its place. When that rotation is not occurring, right? So things will remain, they will develop. Everything is so time bound that right? The liver is becoming bigger, slowly, gradually, stomach is developing, there is formation of, right? And meantime, the rotation is starting, rotation starts. But if the rotation stops, but those organs, they will keep on growing. That is what would be situs inversus with dextrocardia. Right? Because everything is in the form of just a tube. And that tube forms, some portion becomes bigger, right? That's how the heart forms. And then the heart folds. Right? All these things. This is embryology. That's why embryology is, you feel like telling hats off to God. So amazing. Right? So this is dextrocardia with situs inversus. Next. This is, I mean, if you say this is also dextrocardia with the stomach over here, you are 100% right. But this was mistake of the technician. Yeah. You can say that same mistake of the technician, because see what he has used. He has used this sticker, right? The tape margins, right? So that L marker was put and tape marker. This was the mistake of technician. He has put a wrong marker. It's a wrong. PA view is correct. This is a PA view, but the X-ray is ulta. So this is what is called as the pseudo dextrocardia. No one can diagnose pseudo dextrocardia without talking to the technician. You have to actually call the technician because see, he has to take hundreds of X-rays. He is not knowing it, right? So there are in one bowl, there are left marker, right marker, वो lead के markers पड़े रहते हैं, right? There are multiple machines. So they'll say कि just ठीक है, चलो एक mark लिया, left side लगाया, चलो खड़े हो जाओ, dham, X-ray, go out, next patient. Everything is happening fast. So in that process, कई बार गलती से, those who are very senior technicians, X-ray technicians, they don't commit this mistake. But sometimes under pressure can happen. This was a mistake. Right? So here is it. This is super. What can you do? I explained, I told you to see some things last time. I told you to see some things. Can't we find out which other there is hard? Absolutely. I mean, you are so right, because That's what we did in these cases. In such case, there are two things. One, in this particular case, we would tell the patient, just come. Right? And we tell that just auscultate which side you hear. And within seconds, you know that, fine, this patient is definitely dextrocardia. And in this case, no, on the left side only that you are hearing all those heart sounds and it's fine. So it was confirmed. So just by confirm by, I'll just write it, confirm by auscultation. Auscultation. Auscultation is what? What we hear with stethoscope. Here. Stethoscope. Okay. This next one is very super interesting. Do you remember I talked about, this is PA view. I'll be showing you all the PA view. All the PA view X-rays, right? Right now, we won't be making any change in that. But something which is outstandingly different. I told you to look at the tracheal shadow. Right? You remember tracheal shadow. Can you see the trachea? See how is the trachea going? Can you see it? Can you appreciate it? Right? I'll remove these. I'll just zoom this. I'll zoom it. Can you visualize it? Aorta is pushing it. That's right. That's right. Very good. So, but this is the trachea, and then the trachea is going like this, and see here it is dividing. That is the angle of carina. Right? So here, this is the trachea. Normally, trachea would go. How the trachea would go? The trachea would go from antemediastinum, it will go towards the posterior mediastinum, right? It is into the center. And then the trachea, this aorta. What did I say? I say trachea? Aorta, right? Arch of aorta. So arch of aorta from antemediastinum, it goes on to the posterior mediastinum, right? And it is happening in the center, right? And on top of it, right, the trachea is divided. So everything is gracefully done. But what if this trachea is getting compressed like this in this case by the aorta, because aorta is on right side only. This is a case of right-sided. This is a case of right-sided aortic arch displacing or compressing. This is what is happening. We are to receive this. This is the name, right-sided aortic arch. It's right-sided aortic arch. But the point is the trachea is shifted. So in this case, what would really happen? This is the place, right? Trachea is a tough structure. Trachea is a tough structure, and still you can appreciate, I think you can very well appreciate, can you see the decrease in the caliber? The trachea is this much thick. Over here, trachea is this much thick. Correct? So this patient will be having the trouble in breathing, so breathless. And that is what is called as the dyspnea. Dyspnea. Right? Dyspnea means breathless. Right? And another thing, you can even figure it out. You have to ask the patient that is he having any problem in swallowing, because the esophagus is much thinner, much delicate. It is just behind it. So esophagus will also be compressed. Patient will be having difficulty in breathing as well as difficulty in swallowing. Right? Both of these. No, clavicles are open. Clavicles are quite open. Yeah. This is a very typical X-ray. Watch this. Watch this. Look at this rib. Right? What I have done is I have zoomed a portion of pathology. No, there is no lung collapse. Lungs are superb, absolutely fine. There is no lung collapse. That's good. Want to say something? Yes. Sure. Clavicle is behind me. Those clavicle आगे या पीछे कुछ नहीं. You are watching the things in 2D. You are watching the things in 2D. This is not 3D. So आगे पीछे कुछ नहीं. This is the X-ray plate. Patient is here, right? Patient's nose is here. This is the patient. His clavicles are here. His clavicles are near to the plate. That's why we are seeing. आगे पीछे कुछ नहीं. आगे पीछे you can say only when we go for the lateral. Right? Then we can say what is front and what is back. Over here, see, look at the ribs. How big, how. So what I've done is I just zoomed the portion. This digital X-ray, I just zoomed it so that you appreciate, yes, these are the very fine, beautiful ribs, right? So we can see, right? Say this is one rib, right? This is another rib. This is the third rib. See the body of the rib, they are so big, so fine. Right? Same way over here. Now with comparison, right? So this way the entire structure will be made and you can see the clavicle also. Who is this? This Nanni si Jani. Who is this? And with this transverse process of the vertebra also. That is the extra rib. And this rib is called as the clavicular rib, cervical rib. Cervical. Because our ribs, they emerge from thoracic vertebra. So from T1, T2, T, right? That's where the vertebra. But this is emerging from cervical rib. So that's why this is called as cervical vertebra. So that's why this is called as the cervical rib. It's not very rare. In 1 year, if you are into radiology department, you will be watching, say, 50-60 cases of this. Not C1. C1 is way high. C1 to bahut upar. C7. C7. Because this is C1, C1 Atlas, Axis, C2, then C3, 4, 5, 6, 7, and then the downwards. And then comes the T1, T2. Not necessarily. In this case, it was unilateral. I do have even the X-rays in which they were done the bilateral, but many times it is unilateral also. And how would you come to know? Because in case paper, you find the clinical symptoms. Clinical symptoms are that they are having pain in the arm. Right? This is also called as the thoracic inlet syndrome. So I'll remove now all these markings so that you get a clear picture. So that is this one. So that is the cervical rib. So in this case, patient will be having numbness into the arm, right? He'll be having pain into this. So this is the left side. So he'll be having the left side. This is the left side. Okay, so that is the cervical rib. This was the incidental finding. Say, ये तो कहीं पर, it has got no clinical significance. I just पहले ही no clinical significance. It's just for the, sometimes such X-rays they come just to see that how good is your observation. In which number of cervical vertebrae are last one, C7. C7. See this is the, and these are the anterior end of the ribs. Right? These are the anterior end of the ribs, and from here what happens? All those cartilage. Correct? And this is what is called as the costochondral junction. Costa means rib and chondra means vertebra. So the vertebra which started its journey all the way from the back side, right? This is the vertebra and this is the rib which has started its journey from the vertebra all the way it reaches over here. And then this is called as the costo. That means this is the rib, right? Bone, right? And this is the chondral. Chondra is, this is the cartilage. So it is the joint of bone and cartilage. That's why it is called as costochondral junction. So all the way from vertebra to this junction, this is a bone, and beyond that is the cartilage. So that's why what we see over here is these are the anterior ends of the ribs, anterior ends. Right? What you need to see is this anterior. This is what is called as the bifid rib. Bifid. The rib is like this. So sometimes rib will be like this, sometimes two ribs they can fuse together, sometimes one rib can be smaller, one rib can be bigger. All those abnormalities, they are seen incidentally, but otherwise they will not be causing any problem. Right? Totally fine. This is just an incidental finding of the patient mind. It's just an incidental finding. Move these markings so that you can see this, appreciate that this is how the bifid rib would really look like. Yeah. This is such an excellent. How? If I ask you, what would be her age? What would be her age? This is a very typical accident. I'm giving you a hint. Watch less than 10. Okay. Gentlemen, use your logic. 10 साल के की छोटी लड़की का एक्सरे, it will be like a male x-ray. You won't be able to judge the breast shadows which are seen. So obviously she must be at least an adult. She is an old lady. When I tell you that, you will say, oh, yes, yes. I'm giving you a hint. This is because I think this is the last x-ray. The last x-ray. Watch. Don't watch anything else. Just watch anterior end of ribs. That's it. Don't worry about age. Right? Forget about the age. Watch only the anterior end of ribs. You yourself will tell the age. What has happened to anterior end of the ribs? Acha. Just for few seconds, go back and watch this. Or watch this. You can see the anterior ends. Right? There is anterior end, anterior end, anterior end, anterior end, anterior end. Yeah. These are the anterior ends. Correct? And keep this image in mind. And cartilage will not be seen. Cartilages are not seen. And over here, see, all the way. See what is happening. Can you see the cartilages? They are, the ribs, they are reaching all the way to the sternum. All the way. See? I remove the markings. I'll just zoom it slightly. You should be able to see it. still. अब दिख रहा है? Now can you see it? Can you see the whole thing is going like this, right? Floating rib to chhod do. Floating ribs, they are so back, right? Forget. These are obviously not floating ribs now. And floating ribs are 11th and 12th. बहुत पीछे. इससे पहले तो there will be false ribs. But these are the normal ribs which are landing directly. These are the true ribs. The ribs which are landing on the sternum. These are true ribs. But true ribs anterior end जो यहाँ पे खत्म हो जाना चाहिए. It should have been over. Here it should have been over because this portion is the cartilage. Cartilages, they are not seen on the X-ray. Here we are seeing the cartilage. So this is what? This is calcification of the cartilage, which occurs when the person crosses 70, 75, 80. Right? So when the cartilages, they start getting converted. That is the calcification. Right? Got it? So this is a very typical thing. Because of age, old age, and this is the calcification of chondral ends. So all this area, this is the area which is whole harness. I never told it is 10 years. It is 80 years. If someone said 10 years, so I said that 10-year female, so we can't even say that it's an extra of male. That's what it is. It can happen in males also. It can happen in males also. And lungs will not collapse. No, lungs are okay. It is only the outer structure. Right? It is only the outer structure. The breast shadow, it is partially seen. Right? It is partially seen over here. Partially. But I know she was a female. And someone noticed this shadow also. So yes, they are right. They are right. That's what I'm telling. In late age, what really happens is that the breast tissue, they sag. Right? Had it been the young female, but in young female, the calcification, if it happens to this level, then it is abnormal. So in that case, the female shadows, they are seen at a higher level. But as the age increases, the breast tissue sags. So breast shadows, they are seen at a lower level. So sometimes when you are taking the X-ray, right, this much X-ray is taken, but the breast was sagging. So that's why just from these angles, right, you can figure out. And over here, the X-ray was this bigger. Right? Over here, the name and everything. So once the name is there, so you know immediately. It's fine. So this is the area which is to be focused. Calcification. So that's it for today. Thank you so much. And for next time we'll be talking about the graphs, etc. Plus many new concepts. And at the same time, I'll just show you whatever the conditions which we discussed today. You'll see that X-rays of it. All right. Thank you so much. And see you soon. This will be put into that our shared folder just 2 minutes from now.